I want to welcome everyone to the CURiE Conversations. We have two esteemed colleagues and ACRO members joining us today, and we are going to be reviewing a recent CURiE paper related to a unique diagnosis space in GU for small cell carcinoma. So I'm going to invite our first author to give a little background first. Tell me a little bit about yourself and your journey into radiation oncology.
Yeah, great. Well, thanks for our listeners and thanks for having us, Dr. S. So my name is Veronia Fahmy. I'm a third-year radiation oncology resident at Loyola University Medical Center in Chicago, Illinois. And I'm here with Dr. James Welsh, who is the PI of this work. I'm originally here when I was 14, been a Jersey girl since. And then I went to NICOM on Long Island, New York for med school and did my intern year at Hackensack by the Jersey Shore, and then moved here for rad onc residency in Chicago, and I'm loving it.
Wonderful. And Dr. Jim Welsh, welcome, my fellow VA attending. Tell me just a little bit about your unique journey into radiation oncology.
Thank you, Jessica. This is great. I'm, as you mentioned, presently a VA chief of radiation oncology at the Hines VA here in Chicago. Before that, we worked at the University of Wisconsin-Madison together for a number of years. Prior to that, I was at Johns Hopkins, where I was on faculty and had done my residency. After getting my medical degree at the State University of New York, Stony Brook, and my master's degree in molecular biophysics at Yale University. And so radiation oncology is a good fit for me, and it's a pleasure to speak with you and everybody today.
Wonderful. Going forward, we'll utilize and identify each other with first names. But Veronia, tell us a little bit about what got you interested in this project that led to your publication.
Yeah, so like any fresh radiation oncology resident, I try to kind of keep an open mind and keep my mind open about what I want to treat after graduation. And I have had an interest in, many disease sites, but as a future female provider, I don't shy away from, GU malignancies. So when Dr. Welsh had the opportunity to suggest this unique case report of a gentleman with concurrent small cell carcinoma of the bladder and high-grade prostate cancer, I took it on with so much excitement.
Excellent. And small cell is such a unique space in GU, both in the bladder setting and in the prostate setting. Would you give us a brief introduction to the case and some of the aspects that make this a case worth presenting?
Sure. So our paper talks about an 82-year-old gentleman with limited stage small cell carcinoma of the bladder that developed synchronous, very high-risk prostate adenocarcinoma, Gleason 4+5, PSA over 100, during a prolonged treatment delay period caused by necrotizing cranial infection, fistula formation, and inguinal hernia repair. So he ultimately got neoadjuvant cisplatin etoposide and 24 months of ADT, as well as definitive bladder-preserving SIB VMAT approach radiation, delivering 60 gray and 20 fractions to the prostate, 55 and 20 to the bladder, and 44 and 20 to the elective pelvic nodes. And surprisingly, more than 3 years later, he remains disease-free without local or distant or intracranial recurrences. So this case matters because it's, a rare disease. Small cell cancer of the bladder accounts for less than 1% of bladder cancers. It's an aggressive neuroendocrine tumor with early metastatic potential. There's no prospective randomized trials, and treatment is largely extrapolated from small cell lung cancer. So that's where we thought the opportunity of our publication would be to guiding care.
Yes, and I think, as I read through it and as a practitioner in providing kind of general radiation oncology, I think you also highlight on a unique aspect of non or extrathoracic small cell in the debate about PCI. And so I thought that was a good review as well. So do you have, you want to expand on kind of your lit review in that particular space?
So we chose MRI surveillance for this patient instead of PCI. So just as a brief background, brain metastases in small cell cancer of the bladder occur in about 1.5 to 10% of patients. So it's much less common than small cell lung cancer, despite the thought that it could be just as common because of the name small cell. So in order to avoid potential neurocognitive toxicity, we ended up doing serial MRIs for this patient, and they have remained negative for over 3 years.
If I might chime in, it's it was a very challenging question for us about PCI, prophylactic cranial irradiation, or no PCI. So what we did was a comprehensive review of the literature on small cell carcinomas. For small cell carcinoma of the lung, it's a no-brainer. That disease really likes to go to the brain. PCI is undeniably justified. But what about small cell of the bladder? What about small cell of the prostate, small cell of the cervix, small cell of the skin, Merkel cell carcinoma? It's histologically identical to small cell of the lung, but there are molecular differences and there are important clinical differences. Although Merkel cell can go to the brain, it usually does not. Although small cell of the lung can go to the brain, it usually does. Where does small cell of the bladder lie on that spectrum? So we had to do some homework. We had to counsel the patient about the advisability or inadvisability of PCI and the consequences that he might suffer if we did it. In the end, he was the one that said, thanks, but no thanks. That was our recommendation. We were not going to push this, but I think he made the right choice, but it forced us to do a lot of homework on this topic that normally we don't read much about.
Yes, and when you have these more rare cases, I think there's huge value in that literature review, and we certainly appreciate you guys putting it together, that one extra step so that we can share it with our membership in that experience. The other piece that I think is always of value, having treated this case, what are some of the things that would be valuable if you're teaching kind of your colleague who's going to see one in 6 months? What are some of the things that you would like to highlight as take homes from this that you've learned from this case?
Yeah, I think for me personally, the role of surgery and what to do when a patient cannot get surgery or, has a challenging conglomerate of, medical comorbidities and whatever's going on with the patient, then do we give up or can we think about bladder preservation and, the role of chemo and radiation? So this gentleman, had a left hip prosthesis, he had altered pelvic anatomy, prior surgeries, hernia repair. So not only was it challenging from a surgical standpoint of view, but also from a radiation standpoint of view. And so when we talk about like why bladder preservation and radical cystectomy was foregone is because radical cystectomy was discussed, not favored because, he's old, 82, ECOG of 2, necrotizing infection, fistula, multiple surgeries. So therefore the bladder preservation approach was taken. Another important aspect is in terms of the SIB VMAT approach. So, we treated the bladder, prostate, the pelvic nodes simultaneously, different dose levels within one treatment course, which makes it challenging, but that, kind of reduced the overall treatment burden using this approach while maintaining the organs at risk constraints despite the complex anatomy from what I mentioned earlier from the left hip prosthesis and the altered pelvic anatomy.
If I might expand on that a little bit, I can say that, of course, we were all aiming for, especially the patient was aiming for bladder preservation if cystectomy could be avoided. So we did a literature review and found that small cell carcinoma of the bladder, like small cell lung cancer, is exquisitely radiation sensitive. It also responds very well to chemotherapy. The typical cisplatin etoposide regimen should really do a number on this cancer. And in fact, that's what happened. We learned that cystectomy is not inevitable with either transitional cell carcinoma, but especially not with small cell carcinoma. So patient was able to benefit from that. One of the questions that's always in the back of my mind was whether the patient benefited from the urology resident getting a PSA. And the reason I say that is because it reminds me of a case many years ago where I had a patient who was on an organ transplant list, and a urology resident did what urology residents are likely to do or trained to do, and that's check the PSA. And his PSA came back 4.5. They did a biopsy and he had Gleason 3 plus 3 equals 6. And now he's off the transplant list, unless we can affirm that his cancer is under control. So he got 5 fractions of SBRT, and 5 days later, I told the transplant team unequivocally that I believe that this gentleman has been cured of his prostate cancer and is ready to get his transplant. Then I see the same thing happening in our case, where a complicated small cell bladder carcinoma case is with a huge hernia that was in the path of the radiation beams, with a hip prosthesis that's going to make the radiation more challenging, with a perineal infection that was delaying the definitive radiation, and then a PSA was taken to further slow things down. But this PSA was about 140. So now, years later, I'm still not sure whether checking the PSA is a bad thing or a good thing. In this case, I think it was a very good thing, because PSA of 140 in a Gleason 9 cancer could definitely have had a very serious negative outcome on this patient, even if we effectively managed his small cell bladder cancer. So in the long run, I think it was a great thing that we caught this very aggressive, locally advanced prostate cancer and happened to come up with a plan, thanks to Veronia, of managing both simultaneously. A happy coincidence. I would not
Yes.
this man's
I
PS.
think the PSA ad, in many scenarios, the inpatient with poorly differentiated carcinoma, kind of unknown origin, I find myself occasionally suggesting some of the blood markers, PSA included. And it certainly probably did influence your field design. I also appreciate the kind of, when we are devoid of an exact research protocol to follow, the extrapolation of your dose regimens from a nice, moderately hypofractionated regimen out of the James study for bladder, and then the CHIP study for prostate. And as I was ticking off the dose regimens, I was like, oh, I see where these came from, and had to be thoughtful in a space where there's less data. The final question for you all is really about, has this case kind of prompted anything that has changed in your practice? And you highlighted a little bit about the internal debate about PSA or no PSA, but things that would lead to future areas of study, or things that you said, oh, after this case, I've kind of decided that this will be, kind of how my practice changes going forward.
I'll let Dr. Welsh answer this one first, since he has a practice.
Well, of course, at the time of this patient's presentation. We were going through and just coming through a terrible pandemic, and that pandemic forced all of our radiation oncology practices to reevaluate how long patients should be coming in for their courses of treatment, how many fractions are really necessary, because each time they come to the hospital, they're putting themselves at risk of contracting COVID, or they put others at risk if they have contracted it in the community and come to the hospital. So the less, the better. So CHIP, HiPro, Prophet, all of these other hypofractionated regimens became more seriously entertained. And in this case, we certainly applied it for this gentleman in a customized manner that could accommodate his small cell bladder carcinoma as well. But because it was a small cell carcinoma, it forced us to reevaluate the question of PCI. And if we're reevaluating the question of PCI for small cell bladder, what about small cell of other sites? And while I said before that small cell lung cancer loves to go to the brain and PCI is indicated, what are the cases that PCI should not reflexively be applied? And this forces us to evaluate that question, stay current with the literature, and customize our treatment for each individual patient before us. In this particular case, I think we made the right decision by foregoing the PCI, but what about the next unusual small cell case, wherever it may originate? Forces us to think.
Yep, and to piggyback off of Dr. Welsh, we recognize that this is a single case report, so of course there's limitations to, how applicable this could be to, formulating standard of care. But again, this case is so unique that it's worth to throw out there in the literature, especially that the patient had a favorable outcome, and that may reflect the tumor biology, but definitely larger multi-center studies would be needed in this space. But overall, this is a case that shows that, with this treatment approach that we provided the patient, they were able to achieve, durable disease control, even in an exceptionally complex clinical picture with modern radiation techniques, despite having two aggressive GU malignancies.
Mm-hmm. And potentially a question more for Jim. How is this patient's bladder function in terms of toxicity? The better we do getting rid of the tumor, sometimes we then are forced to face our patients with the sequelae of our radiation. Is he happy he still has his bladder, or what does his symptom profile look like a couple years out?
So as Veronia said, this is a case report, which means that it's a unique one-time thing. But I can unequivocally say that he was ecstatic at last follow-up to have a bladder, and in his mind, that bladder was doing just fine. And I suppose he was contemplating the alternative, which 3 or 4 years ago was that you got small cell cancer. You might not be around in 6 months. You have bladder cancer. Even if you are around in 6 months, you might not have a bladder. Here he is over 3 or 4 years later, and he's doing just fine. So in his mind, his bladder is working just perfectly. And that's one of the things that I tell Veronia and the residents and the junior attendings, that unlike emergency medicine, where at the end of the day if you've had a great day or a terrible day, with radiation oncology, you won't know for a solid 3, 4, 5 years or longer whether you've had a good day way back in 2020 or something like that. Being around the block enough times, I can say that I'm very pleased that this patient had a good outcome, and that as a radiation oncologist, I have more good days than bad days. So I feel sorry for our medical oncology colleagues, but this is why Veronia is going into radiation oncology, and I think she's got a great career waiting for her.
Thank you. I appreciate it.
Thank you guys so much for joining us, and that will conclude our CURiE Corner for this topic. We invite everyone to listen. The CURiE Corners are highlighting excellent works that come out of the CURiE Journal. And Veronia and Jim, thank you, and I hope you guys have a wonderful rest of the day. And we'll look forward to more works and highlighting, kind of these unique cases and reading the article so that you don't have to reinvent the wheel the next time we see a small cell, either of the prostate or the bladder. So thank you again.
Thanks for
Thank
having
you.
us.
It's been my pleasure.